chairman, co-chairman. So I'm Dr. Bancha from Thammasat University. My talk is the meniscus root tear with cartilage problem. Meniscus root tear with osteoarthritis is the next step after Dr. Vachirapan. Okay? So this is the anatomy of the meniscus root. You can see lateral is mobile and medial is attached. So the meniscus root will be here, very close to the PCL. Okay, the most common type is a type 2. So you see attachment of the root is very close to PCL, okay, only 8 millimeters. So once the meniscus root tear, as Dr. Vachirapan said, the knee kinematic will be changed, the loss of hook tension, and it get extrusion very fast. So if you need to repair the meniscus, you should come very early. If you come late, the result will not good, right? It's equal to total meniscectomy. So that's quite serious. It looks very trivial, but very serious. This is a natural history when the root tear. So meniscus will get extrusion slowly, and finally the cartilage will gone, right? Within 6 months. This is a natural history. You see that only 3 years, the patient, about 28% need joint replacement. And 80% of the spontaneous osteonecrosis, if you look back in this patient always have meniscus root tear, okay? And degree of the extrusion correlate with the osteoarthritis. So this is a natural history, right? Within 5 years, the cartilage is getting narrow and finally patient needs joint replacement. So if you look back in the patient have joint replacement, nearly 80% had meniscus root tear. This is from the study. And this is a list factors of root tear. If the patient have varus malalignment, old age, BMI, high BMI, female sex, and high KL. Clinical presentation may have pain at the joint line. McMillan test positive. Okay? For the lateral side, lateral root is associated with ACL. Today we not touch the lateral, we're talking about medial. Okay? So medial side is very common in middle age. So in my practice, I prefer to use a one leg standing view because 2 legs, sometimes the patient will not put the weight on. You look at the x-ray. This is the nice study from Dr. Biya from Thammasat University. Right? You can see that one leg standing view, you can see the true axis. These are the 4 classic signs of meniscus root tear. Okay? There will be ghost sign, Krebs sign, and molledema and extrusion. So as I told you, type 2 is most common. Type 2 is a torn side, about 9 millimeters from the attachment. It's a radial tear on the meniscus. So how can we deal with the patient that come late? Yeah, there's malalignment, start to have cartilage problem. So the goal to manage is to prevent the arthritic change of the joint, and you need to repair as soon as possible before the axis deviation and cartilage degeneration. This is a good candidate if the patient come acute, no joint space narrow, and extrusion less than 3 millimeter. Contraindication if the patient come late, like more than 3 or 4 months, start to have malalignment, more than 5 degrees, or start to have some condyle collapse. Yeah, these are the bad candidates, right? If they come late and start to have joint space narrow. Just repairing not enough, UBB fail. Yeah, because I did that before. I will tell you, if the patient start to have joint space narrow, you repair it always fail. And this is the bad poor factor if the patient have malalignment more than 5 degrees or KL more than 3, outer bit more than 3. This is the study, what should be early. You should be within 3 months or 13 weeks. If you are late, then 13 weeks, the result will not be good. Yeah. So the goal of root repair and STO is to protect the repair meniscus and unload the pathologic compartment. Indication is the patient come acute, KL less than 2, no malalignment, and start to have osteonecrosis. Yeah. So these are the indication, root repair with STO, okay? So how much varus is considered to be poor prognostic, right? Like they say 5 degrees, but this study said 3 degrees is enough. If you have only 3 degrees, the result will not be good. And the clinical failure is increased 1.5 times per 1 degree of the mechanical wireless alignment. Okay? So you have too much malalignment, the result will be worse. Okay? 1.5 times per 1 degree. Yeah. And it will fail, of course, if the malalignment was more than 5 millimeters. Okay? So this study showed that the STO alone or STO with root repair has no significance. So the root repair and no root repair with STO result from this study say no difference. But these studies have different idea. They said if you can repair the root with STO, please do that. Okay? But if you have not enough tissue to repair, you can leave it. Okay? The patient will have good result. About osteonecrosis with in STO, 12 patients in this study show that after you do STO in spontaneous osteonecrosis, the range of motion and the clinical outcome will improve, right? And they did study and aspirate the joint. They see that found that the interleukin 6, interleukin 8, okay, is getting better if you do STO. That means the inflammatory process in the joint. This is the inflammatory mediators, right, that improve after you do STO. And also the healing of the song is better. Another option is to do UKA. Because UKA and STO, you need to choose the right patient. So they prefer UKA if the patient had low demand and the cardiac degeneration is very poor. Okay, start to do UKA. So I show you case number 1. Here's the meniscus root tear. The patient come a bit late, start to have cartilage degeneration. Yeah. So we get in, we use the anchor suture, repair the meniscus root, and also STO. Okay. After surgery, the patient doing well. Another patient is very active. He's a marathon runner, 50 years, and he has root tear 6 months after squatting. And this is the repair. So we repair the root, and also we need to save the suture. Previously, I used transtibial technique, but right now I use this is the way I do my root repair and protect the suture, and then tie the suture to the plate. Okay? Or not marathon runner, another patient. She's Kun Pa. She's doing well after that. Yeah. And another patient. This one, he's a doctor. Yeah. He has chronic meniscus root tear and start to have osteoarthritis and severe villus deformity. Yeah. So this one I get in the joint. You see severe axis deviation. The root tear is so bad, right? No big gap. I cannot repair the root. I just trimming, debride, and then we just do the STO. Okay, he's doing very well and very happy after the surgery. So this one, she's 54 years old, housemaid, right? She has a high BMI. So this one I discussed with the patient. I think I prefer to do the UKA for her because the result will not be good. Okay, about the osteonecrosis case, this one 58 years old, very active osteonecrosis. So we do root repair, and after surgery the root healed very well. Okay, and the patient recovered very fast, just 2 months. This is a serious osteonecrosis. So she was advised to do UKA, but the patient denied to do that. But I do STO for her, and the osteonecrosis healed really nice. Yeah, and the result is good. Okay, in conclusions, the root tear rehab should be very slow for the root. Yeah, you should protect the weight. Meniscus root tear is you need to stick to the indication when to repair the root. If the patient come very chronic, you don't need to rush to repair the root because it will be fail. And when the patient have malalignment, cartilage problem, you should do STO or UKA, right, to have the better result. Thank you so much.
Thank you, Bancha. We have 5 minutes left for the question, and I think Ajahn Bancha give very clear presentation that when we need to help people who suffering from OA as well as the meniscus problem in the knee, the treatment is not easy and straightforward. Cannot use the rule of thumb. You have to consider the intra-articular pathology of the cartilage as well as the alignment and the age and the preference of the patient as well. Is that right? Okay.
Good afternoon. Thank you very much.
Please address the speaker that you would like to respond to your question.
Dr. Professor Bancha. In one of the cases, you have showed high tibial osteotomy for a doctor. The wedge is more than 12 mm, and you have not used any wedge or any bone graft, and also distal femur varus is also there.
Yeah.
Would you have not considered distal femur osteotomy and also tibial proximal tibia or only proximal tibia?
Yeah.
So what is your cutoff for that?
So this patient is actually a bit complicated. I did not mention, they also have flexion contracture. Okay? He's just 44, he's very active. So first I get in and I do arthroscopic release, the posterior capsule, and then I manipulate the knee to get full extension. And in the theater, we check the collection. We use the CT scan and calculate. So this one, we found that the joint space after we collect is still parallel to 4.
Okay.
So we did not do the double osteotomy.
Okay. Okay.
Yeah.
Thank you. Thank you.
Thank you.
I have a question for Dr. Bancha.
Yeah,
that is about the when you do the high tibial osteotomy for patient of SONK, S-O-N-K. There is a stage for stage SONK, and do you have a cut line for the staging? Because for the advanced SONK, I think the HTU can have less.
Yeah.
Thank you.
So it depends on, each song is like osteonecrosis. Yeah. So we try to look intra-op. If that fragment is stable, I actually forgot to mention, I open the flap. I cleaning and remove the bad tissue, make microfracture, and try to repair that song back. So the result after the STO with the this song repair is pretty good. Yeah, if it's unstable or it's detached, when you get in, you need to take it out, and maybe you need to change the plan. Yeah.
Okay, so in the literature, it was mentioned that the stage 1 and 2 SONK is kind of
stable,
irreversible, can be reversed.
Yes, right.
And the stage 3 and 4 SONK usually cannot be resolved.
Yeah, I prefer stage 1 and 2.
1 and 2.
That's
okay.
right.
Thank you.
Thank you.